Good morning, good afternoon, good evening, everyone. Welcome to this press conference. My name is Guy Marks. I'm the president of the International Union Against Tuberculosis and Lung Disease, which is also known as the Union. I'm joining you today from Sydney in Australia, and I'd like to begin by acknowledging the traditional custodians of the land on which I'm sitting today, the Gadigal people of the Eora Nation, and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander people and other First Nations people who are attending this conference today. Welcome to this official opening press conference, and which we hope will set the tone for an exciting week ahead of us. The Union is the custodian of this 52nd Union Conference on Lung Health, and it's taking place this year virtually again, of course, due to the COVID-19 pandemic. We have with us at this conference some of the world's most prominent global health leaders. The WHO Director General, Dr. Tedros Adhanom Ghebreyesus, the Indonesian Minister for Health, Dr. Budi, South African Minister for Health, Matume Joseph Fala, South African Home Affairs Minister, Aaron Motsoaledi, and the CEO of the Gavi Alliance, Seth Berkley. We're also joined at this conference by many leaders from the scientific community, including this year, many infectious disease experts working outside the field of tuberculosis, of course, because of COVID. The Union is also proud to have once again provided the opportunity for over 200 lung health survivors to this conference as sponsored delegates. We have survivors speaking across a multitude of panel sessions, and they also own the Community Connect program tool within this conference. It is our hope that the Union 4,000 strong delegates come away from this week energized, both with hope and with solutions to some of these really challenging questions that are facing us at present. Before introducing my esteemed colleagues who are with me here today, I wanted to make a few points to set the scene for both this press conference, and for our week. This time last year, we were still trying to grasp the impact that the COVID-19 pandemic would have on the global TB response. We, of course, feared that it would be bad. And now we have data which have borne out those fears, released in last week's WHO Global Report, which indicate that we've lost about a decade in progress against tuberculosis. TB deaths have increased for the first time in 10 years, and case finding is falling dramatically. My colleague from WHO, Teresa Kaseva, will elaborate more on this shortly. But it's also the very nature of the COVID-19 vaccination response that has literally put TB in its place. On the one hand, we've seen this extraordinary scientific progress to produce 7 WHO-approved vaccines against SARS-CoV-2 in less than a year. This has been truly remarkable and inspiring. Yet I know many of us who work in the field of tuberculosis feel concerned, at least, that equivalent efforts to develop a TB vaccine have not been committed or funded. Until COVID-19 came along, TB was killing more people than any other infectious disease, but you'd never have known it. In fact, many people believed that TB had ceased to exist as a global health problem. If we spent a fraction of the energy and resources that have been spent on COVID-19 vaccines and treatments and getting them into wealthy countries, we'd have stopped TB in its tracks long ago. And of course, indeed, we have stopped it in many wealthy countries. I dare say, too, that no one who works in the TB world is in the least bit surprised by the simply shocking and dangerous COVID-19 vaccine inequity that we're currently living through. The failure to deliver COVID-19 vaccines, and I suspect in the future, new treatments for COVID-19 to low and middle income countries, and the failure to end TB in low and middle income countries are two sides of the same coin. Essentially, they represent devaluation of human life in poor countries. And these devastating mortality numbers from the WHO Global TB report indicate that TB will soon return to be the biggest killer of infectious diseases. This is a preventable tragedy. So all this sounds incredibly bleak, but I think we have some reasons for optimism. We're optimistic because we're now seeing some very important scientific developments, some of which are going to be reported at this conference, that will help us to make major inroads against tuberculosis. Newer and shorter treatment regimens are becoming more commonplace. Diagnostics are becoming smarter and cheaper. And new technologies are helping us to better understand transmission and drug resistance. COVID-19 has even seen a renewed interest in face masks in the TB world, both for reducing transmission and, as we'll hear soon, for detecting TB infection in people who have it. We've been, as an organisation, collaborating with a world-renowned designer, Gary James McQueen, of the Ethical Mask Company, to develop this new and exclusive, Breathe Ethical Face Mask. The collective mission of this task was to reduce unnecessary waste, offer a chemical-free mask, and support those with tuberculosis and lung disease. I had hoped that we would be able to demonstrate it to you today, but the vagaries of the postal service around the world at this times of COVID-19 have meant that we haven't been able to distribute them to ourselves in the short time that we had since organising this media conference. So you're going to have to search online to find the Ethical Mask Company website where you can order these masks. Once the initial target of 1,000 masks has been purchased has been hit, the masks produced and 25% of them, each mask sale will be donated to the union. We aim to achieve 50,000 mask purchases. So this will help to support the use of ethical and disposable biodegradable masks, and also to support the union. So before introducing my esteemed guests who are sitting with me here today, let me run through some of the housekeeping things for this press conference. This is a live press conference and it's being recorded and will be available on the conference YouTube page shortly after it has ended. Today, we'll be hearing brief remarks from all of our speakers, and then I will open up for questions from our media representatives attending today. When you're ready to ask a question, please send it via the question and answer, the Q&A function, the button at the bottom of your screen. And if you could indicate in that your name, the media outlet that you represent, and to whom you would like to direct the question, that would be useful. Please keep your questions brief and we'll begin. So to begin with the first speaker, I'm really delighted to introduce to you the first speaker today. That's Dr. Teresa Kaseva, who's the director of the WHO Global TB Program. She's going to tell us today about some of the findings released by the WHO TB Program in their report last week and discuss some of the challenges going forward. So Teresa, over to you. Thank you.
Thank you very much, Guy. Good morning, good afternoon, good evenings, ladies and gentlemen, dear colleagues and friends. On behalf of the World Health Organization, I would like to thank you all for your interest, for your focus on TB. Indeed, situation is extraordinary, not only due to COVID-19 pandemic, but also due to the so-called old pandemics, and the situation is becoming worse, if not to say critical. While 66 million lives were saved due to TB prevention and care since the year of 2000, the COVID-19 pandemic has reversed years of progress and efforts in fight against TB. For the first time, as I already highlighted, in over a decade, WHO is reporting an increase in tuberculosis death. Tuberculosis is the world's second top infectious killer, just after COVID-19, claiming over 4,100 lives a day. Approximately 1.5 million people died from TB in 2020, including more than 214,000 among HIV positive people. It's a leading killer of people with HIV, major contributor of antimicrobial resistant related death. And I would like in the same time to highlight that TB is a preventable and curable disease. We have much more opportunities for the successful treatment, and at least 85% of people affected with TB could be successfully treated. Over 9.9 million people fell ill with TB last year. Majority men, 5.5 million, 3.3 million women, and more than 1 million children. 8% were people living with HIV. I would like to acknowledge the huge efforts, the joint efforts made by countries, health workers, community health workers, all the partners and stakeholders to mitigate the impact of COVID-19 pandemic and combat not only COVID, but also TB. Significant work undertaken to ensure continuity of essential TB services, and WHO is closely working with the partners to provide support and in the same time monitoring the situation. So, but we must say that COVID disruption severely impacted access to essential TB services, with far fewer people being diagnosed and treated or provided with TB preventive treatment. The number of people newly diagnosed with TB dropped from 7.1 million to 5.8 million this year. Around 4.1 million people with TB missed out of access to care, or were not notified and were not reported to the authorities. This figure is significantly up from 2.9 million in 2019. Prevention efforts are also lagging behind, with a reduction in provision of a TPT. Only 2.8 million people access TB preventive treatment. This is again drop around 21% in compare with the last year, I mean 2019. And TPT could be a kind of game changer, not only for the progress in TB, for the reduction in TB incidence, but in the situation of new pandemic, can protect people at least from tuberculosis. Drug-resistant TB remains a public health crisis. The number of people treated for drug-resistant TB fell by 15%. From 177,000 to 150,000 in 2020. It means that only approximately 1 in 3 of those in need receiving access to treatment. Now, if we will look at the progress according our commitments and targets we've made all together before the pandemic, again, there are not so many good news. Reduction in the number of TB deaths between 2015 and 2020 was only 9.2%, but we've committed and the target was 35%. Of course, we have some examples in the regions moving faster, progressing better. Of course, they also have been affected by the pandemic, but I can bring example of the European region managed to reach the milestone of the MTB strategy. African region, again, was progressing quite well before the COVID pandemic, but now situation is different. 90.8 million people were treated for TB in the period of 2018 and 20. It's just the halfway towards our 5-year targets to reach 40 million by treatment, according to the UN high-level meeting political declaration. Some 8.7 million people started TB preventive treatment in the same period. It's about 29% of our target of 30 million. TB remains critically underfunding with committed funding for TB prevention and care, as well as for the research and innovations. So global spending on TB care fell from 5.8 million to 5.3, which is less than a half of the global target of 13 billion annually we need. For research and development, we're spending less than 1 billion. It's absolutely impossible, and we can't expect new vaccines developed if the spending are so small. But we urgently need new effective vaccines and other tools. In addition, we know that TB is a social disease, and we should address also broader determinants of TB epidemic, and it requires multi-sectoral engagement and accountability. We can see the growing impact of the determinants like poverty, malnutrition, and further socio-economic crisis will drive TB epidemic unless urgent measures will not be undertaken to restore services and to provide all needed support, including social support for the most vulnerable and the poorest. We have just 1 year to go to reach the 2022 targets. We've started preparations for the second UN high-level meeting in 2023, working closely with partners. There will be, again, opportunity to put spotlight on TB and to have a comprehensive review of the heads of states, how they put in place their commitments, how their commitments were followed by real actions and real investments in TB. We must stay focused until the job is done. So in closing, I would like to stress once again that we have before the opportunity to save lives of millions, to preserve resources and demonstrate success of efforts to end TB, despite a crisis that come our way. We must keep the momentum going to stop the spread of this preventable and curable disease and reach those affected with the care they need. We must keep the momentum going. We're running out of time. The clock is ticking, and it's time for urgent actions to end TB. Thank you very much for your attention.
Thank you very much, Teresa, for bringing us that really sobering news, but also showing us how we need to move forward and what we need to do. Our next speaker is Dr. Uvistra Naidu. Uvi is a pediatrician specializing in TB. He's a scientist and he's an advocate, but he's also a survivor, both of multi-drug resistant TB and now from two bouts with COVID-19. His is an extraordinary story of courage, and I'm very pleased to welcome him to this press conference and to ask him to speak to us now. Thank you, Uvi.
Thank you, Guy. I speak to you all today out of sincerity and just sheer humility. I ask myself why the international public, for the last few years that I've encountered TB in my life personally, has not taken an interest in 1.4 to 1.5 now million people that have died. I think we can question funding and also political will, but I think we also need to start looking within ourselves. We've all been humbled in the last 20 months of our lives. And if I look back 2.5 years ago, if I sat in a lecture, being a clinician, and if a basic scientist was giving a lecture about TB, there would be such intimidation from the clinical half, not really knowing what the scientists were talking about, and vice versa when a clinician spoke. And I see this silo developed in the TB world in the 13 years I've been interacting with tuberculosis. And I think it prevents this chain of actually networking us closer to the patient. I hope by relaying my story to you today, you'd be able to better understand that I come from a place of privilege being a doctor, but I speak on behalf of the million patients that do suffer. And I do see at bedside quite frequently in South Africa. This world needs two types of people, leaders and followers. The greatest leaders are the ones that innately just decide to lead and to follow, and they have inspired us over centuries. But we also need to ask ourselves today, what is your role? How are you going to care? Are you going to lead? Are you going to be followed? Are you going to be a follower? But how are you going to be part of the story that we find ourselves in today? We've seen the Global Health Report. It does look very sobering, as Guy has spoken, and Teresa. We need to roll up our sleeves and really work hard in service for those that are suffering the most. And today there are many throughout the world that have lost families. I've seen my medical doctors just really battling. I've seen nurses cry at bedside over patients lost. I think we all sit and we also acknowledge that there's just a momentum of public mistrust against science. It's been fueled by politics, but it's also been fueled by us. And I think we need to really come to the table to ask ourselves, what can we change within ourselves to gain momentum back to end TB, but also create a world where COVID-19 is better controlled. This year in my life, I've seen death personally. My whole family was admitted for COVID-19, losing my dear father. I've seen nurses and doctors cry, and I really question, where do we go from here? My story is just the tip of the iceberg. I hope you can think of the average poor person living out there that has a far worse stretch than I do right now, though I'm still recovering from long COVID-19. So in 2008, I was diagnosed with drug-resistant tuberculosis. It took me 3 years, 1 week and a day to be cured. I had to bear lots of complications. I developed a complication called Stevens-Johnson syndrome due to the dated TB drugs out there. I had bleeding skin lesions, my mouth, lips, body. I had drug-induced injury, severe peripheral neuropathy, depression, suicidal ideation. I had a catheter to give me IV medication for TB, and that had gone septic while I had struggled to get back to work as a doctor. I thought the end was near, and I had many close encounters with death. I experienced caring and good support from my family, which very few of my patients experience in South Africa. I really battled. I stayed 48 kgs for about 1.5 years, not responding to the TB drugs, until my father, who was a caring academic, sat with me daily, and we began reading basic science journals about mouse models, PKPD and basic science of TB. And I got cured after those 3 years. I decided to not just merely be a survivor, as some name me. I really wanted to champion those patients that aren't heard, don't have a platform. So I began learning TB basic science as well as clinical research. And I really learned a lot moving forward. Move forward to 2020, I picked up severe COVID-19 twice. I've got complications to my heart, my lungs, my adrenal glands recently, we've just found out. And as you can see, I'm still intermittently oxygen dependent. I've lost a father. I've lost 25 medical colleagues, doctors and nurses. I'm beyond humbled. I think the greatest thing that we can show the public out there is that to actually just describe with the TB front and the COVID-19 front, we don't know what we're doing just yet, but all we can do is show caring. And we can't hold the patient's hand. We can't hold the general public's hand and tell them that we're guiding them in hope. We can give a voice for those that suffer, much more than we've done in previous years. I'd like to see the TB front where clinicians and basic scientists come together, where we champion the patient suffering. I'd like to see greater unity with that. I'm guided by hope, and I look forward to the rest of this conference and hearing of the great innovation that has come before us, but there's plenty more we can do. I thank you.
Thank you very much, Uvi, for sharing that extraordinary story that you've had, and a story of courage and commitment to helping others in the face of tremendous adversity. Our next speaker is Claire Fallani. Claire is a film and television actor and since 2019 has been the union ambassador. We're delighted she can be with us today. She joined us at the virtual conference last year, and she also joined us at the 50th Union World Conference, which seems now a long time ago when we were in Hyderabad. And on that occasion, she had the opportunity to meet with a number of members of the TB survivor community. I know she's passionate about the role that she's playing for us, and that the community can play in the TB response. So I'd like to invite Claire now to say a few words to us. Thank you.
Good morning, good afternoon. I know that we're sitting virtually today, but I'd like to say hello to all the journalists who are attending this press conference. I'm always grateful, and I'm honored to be here today with these committed people who are trying to make a difference in the tuberculosis epidemic, especially during these unbelievably trying times. Uvi, I salute you for your courage and to face such adversity. You are really an inspiration to all of us. As Guy said, it's been 2 years since I was in Hyderabad, India at the 50th Union Conference, spending time with some of the most extraordinary and inspiring people who have survived TB and who are continuing to raise awareness of the disease and educate their peers like Uvi and bring an end, or try to bring an end to this horrible disease. I was privileged to visit an extraordinary group of women working to prevent TB in their own neighborhoods in the Malakapet slum community outside Hyderabad in India. These women were absolute true warriors. In Hyderabad, they opened my eyes because speaking with TB survivors from around the world taught me that to end any kind of epidemic, you need community. You need it to be upfront and center of this response. And we repeat the importance of this because it's crucial. And after listening to Uvi's story today, a year and a half into the COVID-19 pandemic, we know that this is as true as ever. This horrific pandemic has disproportionately affected and killed the poor and the vulnerable. Migrant laborers, those people who are living with pre-existing conditions, those people living with comorbidities such as diabetes and hypertension, those brave people who are working on the front line, who could not, and in many countries still cannot afford to not work. The mental health toll of the pandemic is huge. And as I saw in Hyderabad, mental health is also something that accompanied people living with TB. The stigma. And even more for those people who have lived with it a second time. My heart goes out to people like Uvi, who have had to endure the unconditional burden of COVID-19. And yet, the truth is that voices of these communities have been largely ignored and stifled in many countries across the globe. I recall the WHO DG Dr. Tedros saying many months ago that the defining symbol of the pandemic has been the failure of the world to share the information in what are these most connected of times. That's certainly true. But I also think the absence of the voices of the most affected by COVID-19 has been just as defining. As Guy says, ought we be surprised that vaccine inequity has reared its ugly head? It is extraordinary just how quickly we, in the vaccinated, wealthy North, now we're socializing, we're taking summer holidays, we just plain forget. forget that most people in sub-Saharan Africa, for instance, are still not vaccinated and continue to deal with the risk of infection, illness, and death as they go about their lives. It is a case of out of sight, out of mind. And this is just like TB. And it has been for TB for too long. As both the HIV and TB responses have shown, we need community to partner with the scientific community, uphold the sanctity of evidence-based policy, and hold governments at all levels accountable when they are making decisions that affect the lives of their citizens. And that also means vaccine development and delivery. We're getting closer, but we are still, despairingly, do not have a vaccine for TB, which is unfathomable at this point. But as Guy says, we are seeing some amazing headway being made in developing other tools to prevent and treat the disease. But as the COVID-19 pandemic has shown us, science has to be accompanied by the political will to humanly invest in the health of all its citizens. Thank you. Thank you for listening.
Thank you very much, Claire, and thank you for your passion and for your speaking up on behalf of those who are not heard and not seen and forgotten. I now want to turn to the first of the scientists who are going to speak about some of the key scientific presentations that are going to be delivered during this week. There's no doubt that COVID-19 pandemic has particularly refocused attention on how infectious diseases transmit from person to person. And we're going to hear today about some interesting innovations in relation to TB that are relevant to this issue of disease transmission. Our first speaker is Ryan Dinkley. Ryan is a PhD student based at the Centre of Excellence for Biomedical TB Research at the University of Cape Town in South Africa. He and his colleagues have come up with some fascinating research that questions some of our long-term assumptions about how tuberculosis is transmitted from person to person. So Ryan, over to you.
Thanks so much for the introduction, Guy, and thank you to the other speakers for sharing your stories and your research. Truly inspiring, and I think it really sets the context of the fight that we're up against. So thank you for sharing. The title of the work that I'll be presenting at the conference this week is "The Cough-Independent Aerosolization of Mycobacterium Tuberculosis Suggests a Significant Role for Tidal Breathing in Tuberculosis Transmission." And here in Cape Town, my research group, we're centered on studying TB transmission, as is evident. And this is really based on the assumption that chronic cough is commonly assumed to be the dominant source of MTB aerosols. However, the development of pathogenic and therefore symptomatic infection is actually a relatively rare outcome when you look at the number of asymptomatic infections in South Africa, when you look at the prevalence of latent infection globally. And this really, and when you look at the rates and the force of transmission, it leads to two possible interpretations. Firstly, that transmission via symptomatic and infection is highly efficient. So when people cough, there's a high efficiency in transmission. Or interpretation two is that transmission is happening through cough-independent means that we yet don't know about. And this research really was found in the development of the respiratory aerosol sampling chamber, or the RASC, by Robin Wood over the last few years. And he has really championed the collaborative effort, pulling together clinicians, engineers, and microbiologists to develop a really highly efficient aerosol sampling chamber that's enabled us to ask several questions. And up to this point, when we've studied bioaerosols, we've never required patients to have an induced cough or to force cough. And yet, without fail, we're able to identify MTB within their bioaerosols. which lead us to again ask this question: is cough really necessary in TB transmission, or is there something that we're missing? And so recently, earlier this year, we published a paper that was comparing deep breathing to coughing, and we're showing that even just in really deep exhalations, you're able to aerosolize Mycobacterium tuberculosis without cough. And so this research that I'll be presenting at this conference is taking that a step further, where we're simply looking at tidal breathing, so normal breathing over 5 minutes, and investigating how much Mycobacterium tuberculosis is aerosolized during that time. But what's really interesting and useful about our system is that we've been able to combine particulate counts, CO2 measurements, and bioaerosol capture, and then MTB enumeration, and really get a full picture of a comparison between coughs, tidal breathing, and deep breathing. And what we found is that actually, in terms of particle aerosolization, the size distribution, the type of particles between all 3 maneuvers are very similar. There's different absolute amounts. Obviously, the cough produces a lot more particles than just the breath, but there's a sort of a conservation of relative abundance of particle sizes. And this actually is consistent with the mechanism of particle aerosolization, which was published several years ago. So it really seems that our research is founded in some sort of logic that actually particle aerosolization is happening in a conserved mechanism between all 3 maneuvers. And ultimately, what our research found is that the daily contribution of MTB into the aerosol, what matters most is the maneuver frequency or the event frequency as opposed to the event itself. And the major conclusion of our study is that tidal breathing in a day likely contributes about 90% of the aerosolized Mycobacterium tuberculosis compared to cough, which would suggest a completely new mechanism for transmission. And it almost impose a challenge as to how do we then stop transmission, because symptomatic screening then, if tidal breathing is important or even close to as important as cough, symptomatic screening is now going to be a challenge. Sort of cough-based interventions, coughing into your sleeve, and that sort of thing is not necessarily going to be useful. So there's raise questions as to how do we go about disrupting transmission chains? And I think along with all of the comments that were raised already, I think shedding light onto TB transmission is a really important area for further research. I think is really where our work is pointing to at the moment. Thank you.
Thank you very much, Ryan. This is really important work and really highlights the importance of the need to go beyond symptomatic patients in case finding and to essentially to expand into active case finding. And I know that your study is being taken up by the New York Times. It's being published, so congratulations on that coverage for your study.
Thank you.
It's very important work. And there are some more questions, I think, about your study that we'll come to a bit later. So the next speaker is Jane Sutherland. Jane is the head of the TB research group at the MRC unit in the Gambia for the London School of Hygiene and Tropical Medicine. Jane and her colleagues have been involved in trialling a fingerprint blood test for the diagnosis of patients with TB. And she's going to tell us a bit about that today. Thank you, Jane.
Thanks, Guy. Thanks for the introduction. So I just want to put this into context a little bit. So I work at the MRC unit in the Gambia, as Guy mentioned, and we see 200 patients a day come through our outpatients clinic. So we have laboratories nearby. We have the patients coming through. Some of them will have symptoms that suggest TB, and they will be screened by our team and given the appropriate tests that they need. We're a well set up lab, so we have the right level of tests. You know, we're the only place in Gambia that can do TB culture, for instance, because you need special facilities for that. TB culture takes a long time. So what you want is a test that will give you an answer quite quickly. You want a test that does not rely on sputum, because a lot of children, a lot of people living with HIV cannot produce sputum, or they have a very low pathogen load in there. So WHO have recommended a development of a triage test or a screening test for TB that can basically direct us to know who needs further assessment using the more complicated and expensive techniques. And we know with this recent WHO report, the impact of COVID has increased the number of patients who don't get diagnosed. We have 10 million new cases each year. Normally, prior to COVID, we were getting about 3 million that missed a diagnosis. And that's largely due to access to appropriate diagnostic tests, access to clinics. With COVID, we've seen the impact is that's increased now to 4 million, over 4 million that do not get a diagnosis, that are transmitting to the community, that are not put on treatment, that will end up, increasing the mortality rate and the morbidity rate. So it's really essential that we have this test. And so we've been trialing, there's a test developed by Cepheid. So this has gone from basic science all the way through to translation. So we know about mRNA now because of COVID vaccines. So it's testing in a finger prick of blood, so 4 drops of blood, 3 genes that are present in your blood that can tell you, well, we hope, can tell you whether you've got TB or you've got some other respiratory disease. So TB or not TB. And so we've been trialing this in a big consortium in South Africa, Gambia, Uganda, and Vietnam. And I'm just presenting interim findings for the conference on Friday of almost 200 patients from these countries. So we have a group of those who were confirmed to have TB microbiologically with using another test by the same company called the Gene Expert Ultra. And those confirmed not to have TB. And it's the first test that's been shown to meet the WHO requirements for a triage test. So we have high sensitivity and we have high specificity. It doesn't reach the mark for an actual diagnostic test, but it does mean that we can screen patients, and those that have a high likelihood of TB, we can send for further treatment. So as I said, this is interim findings at the moment, and we're still evaluating in children who generally can't produce sputum when they're very young, and in a larger cohort of adults as well. So we're hoping that the results hold up, and we'll be able to use this as a screening tool for TB in the community.
Thank you very much, Jack. That's really exciting, and I think, as you say, particularly for children, for patients who can't produce sputum, patients with extrapulmonary TB, I guess as well, it's going to be a very exciting development that will help us eventually with diagnosis, or at least with further investigation of patients like that. Thank you. So the last speaker in this session is Carolyn Williams, who's from the Department of Respiratory Sciences at the University of Leicester in the UK. And she's going to talk to us about face masks, which I alluded to before. And she's going to talk to us about how these might be used actually in the diagnosis of respiratory disease, including TB. So Carolyn, over to you.
Thank you ever so much, Guy. Hi, I'm Caroline Williams from the University of Leicester in the UK. For the last 10 years, actually, our group's been looking at face masks, so before they became quite as commonplace as they are today with the COVID-19 pandemic. And we were wondering, we wear a face mask to prevent us transmitting anything to other people, but could we catch what we're transmitting within those face masks? And we have developed a novel non-invasive tool that has a sampling matrix within the face mask that can capture respiratory pathogens such as tuberculosis, COVID-19 and other pathogens. So previous work that I presented last year at the Union meeting showed that we can capture MTB directly exhaled from breath, and like Ryan's work, we don't require anyone to cough. And in fact, again, like Ryan's work, we found that cough wasn't needed to detect MTB as readily as in sputum. And we were able to collect MTB when people couldn't produce sputum, and while they were sleeping, and earlier in their disease than when they can produce sputum. The work that I'm presenting at the conference this year is looking at transmission. So can what you exhale onto a mask predict how infectious you are? Now, with colleagues such as Jane and everyone at the MRC unit in the Gambia, we undertook a prospective household transmission study where we asked somebody with TB before they started treatment to wear a face mask just for an hour. And then we looked at how much infection or how many cases of infection of MTB there was in their family, in their household contacts. And we were able to show that a face mask sample can predict TB infection in households better than sputum. And there's a threefold increase in risk if you are exhaling a large amount of TB detected by a face mask in the infectivity of that person compared to people not exhaling by a face mask. And we weren't able to see this with sputum, which has been shown before in previous studies using a cough aerosol sampling system, which is a high resource intensive system. Now, face mask sampling is now ubiquitous. We all wear them continuously. So it does offer a platform by which we could just detect respiratory pathogens such as TB, but also COVID-19 and other respiratory pathogens to be able to really understand what people are exhaling. As Ryan said, TB requires transmission to survive. And so if we can understand who the most infectious people are, we could potentially put interventions in to try and prevent them transmitting the disease more. So hopefully our work with Jane in the Gambia and the University of Leicester will be able to move forward to understanding a novel diagnostic for both TB as a diagnostic, but also as an understanding of how infectious somebody is. Thank you.
Thank you very much, Caroline. It's great how these presentations we've heard about today actually all fit together in some way. They're all interconnected, and they're all part of the emerging picture of how we can move forward in TB elimination. Now we've just got a few minutes now, up to about 15 minutes, to answer some questions from the media representatives who are here. I just remind you, if you could use the Q&A button at the bottom of your screen and tell us who you are, where you're from, and who you're directing the question to. And we have one question, actually we have more than one question, from Jenny Ravello, who's a reporter from DevX. And her first question is actually directed partly to me and also to Ryan Dinkley on his study on transmission during breathing. And she asks, on studying regular breathing as a main driver of TB transmission, what are the practical implications of the study? Maybe I'll ask you, Ryan, to first of all respond to that, and maybe I might add something after that.
Yeah, so I think, as I said, I think that the first implication rather is that it means that finding and targeting a nationwide intervention against transmission is going to be very difficult. I mean, I agree with what Caroline is saying. I think being able to identify the most infectious or people, yeah, in a way that samples by aerosol and is not based on sputum or some other diagnostic which may not work, might be an effective way to detect people. But yeah, I think that the challenge is then developing a system or that enables us to actually find these people and intervene in an effective way. Part of what we're looking at is also the effect of treatment on MTB within the bioaerosol over time, and we have interesting data coming through that. And I think, you know, if we knew, well, if we find the people and we could treat them or something like that, it would be a potentially useful way. It's just, then I think the implication is that the magnitude of the number of people that may be infectious and transmitting is on a large scale. And I think that's where the challenge comes in.
Thanks, Ryan. I might just add, I think there are several implications here. One, I think, is that it suggests that you, as I mentioned actually when you finished speaking, that we can't rely on finding people who cough to identify infectious patients with tuberculosis. We have to recognize that to find infectious patients with tuberculosis, we need to diagnose patients who are not coughing. And since coughing is usually the symptom that causes people to seek medical care, it means that we need to look for patients who are not seeking medical care, which ultimately means active case finding. The second implication is that it means that we need to consider much more airborne transmission of TB, as we have learnt to with COVID, that airborne transmission of respiratory infections, including TB, is very important, and that we need to consider how to control that more effectively, which may involve masks, but it also probably involves better ventilation and perhaps air filtration and methods of keeping the air safe. So that would be my comments about what the implications are. I'll just ask, there's a follow-up question about the same study, which I'll ask to Teresa, about how would you see this affecting WHO guidelines? What impact might it have on WHO guidelines? So I'll let you answer that question, Teresa.
Yes, thank you. So this question actually shows that we know a lot about tuberculosis due to its long history, but in the same time, there are gaps in our knowledge as well. So, and we in WHO, especially in the last 2-3 years, are updating, as you could see, our guidelines quite frequently. But the main condition is evidence. Once we will have evidence, we acknowledge this important study and all the research-related activities. But once we will have evidence, then we will be ready to review it, and then it will become clear how it will affect, and hopefully hopefully we will receive soon this evidence, and without any delays, we'll be ready to send our comments and do, if necessary, updates.
Thank you, Teresa. I'm going to put a question from Elaine Fletcher, who's from Health Policy Watch. This is also to Ryan. Was your research informed at all by knowledge about aerosol transmission of COVID, and how could you compare aerosol transmission of COVID to aerosol transmission of TB?
So for this portion of the work, not directly. We've been working on this technique and this study for a long period of time, and it's been sort of the natural progression of question and answer that led us here. We did consider COVID. Obviously, I'm not the decision-making person in the group, and we did chat about whether we should implement our system to COVID and then the ethics applications, and it would be almost like turning a ship. But yeah, so COVID kind of came across our lines during this process. But no, the research was informed by previous research in transmission space that we've been doing. Can you compare that to? It's a very interesting question. I think from a physiological standpoint, if you that aerosols are produced in the peripheral lung through a mechanism called fluid film rupture, and so basically when you breathe in, you generate aerosols. When you breathe out, you release them. If an infectious agent is within the peripheral lung, conceptually it can be breathed out in that mechanism, but biologically from the side of the virus, I suppose it depends on where it's typically being aerosolized from and its ability to survive in aerosol droplets, and that's, so I'm not an expert on COVID itself, but no, our research is primarily TB based.
Thank you, Ryan. The next question is from Rita Widyadana, who is writing from Indonesia for the Jakarta Post. She has two questions. I'll ask one to Uvi Naidu. The number of TB patients and deaths has always been seen as statistics rather than real people and their suffering. Where are we in missing this point?
Thanks.
What are we missing in this point, I think? Yeah.
Thanks, Rita. Well, as the other speakers and historically with TB, we've always rattled on, but TB is grossly underfunded. We haven't attracted more scientists and the best scientists as a result. And that is why we're always behind in the race. But as a result, I personally, as a patient doing science and clinical, when I compare what has happened in the HIV/AIDS front, in the cancer front, there's a lot more activism that happens on behalf of the patient. And I genuinely feel that the union has to be given so much credit. They've introduced basic science into the platform a few years back. They really have been championing a lot of advocacy groups, but I do feel we're a little bit more rigid in the TB world, and I'm hoping that can be changed as long as I'm alive.
Thank you, Uvi. I've got another question from Jenny Ravello at DevX. This one's to Jane Sutherland about the finger prick blood test. What are the advantages and limitations of using this finger prick blood test compared to current tests? And is it now being used in low and middle income countries?
Thank you. What I didn't mention during my talk is that the test gives you a result within 1 hour. So that's a real advantage over a lot of other tests. So the gold standard currently is culture, which takes at least a week and up to 6 weeks to give you an answer. There is another molecular-based test by the same company, but that relies on sputum. And we know that particularly in children, people living with HIV can't always produce sputum. So we need a test that's non-sputum. So this finger stick blood is easily accessible and gave us a result within 1 hour of the patients turning up to clinic. So it was excellent in respect to that. And then in terms of so accessibility is an issue because you still need the machine. So we're hoping down the track that the simplicity of the device will increase, but that's for the company and the developers to determine.
Okay, so look, thank you very much, everybody. I'm afraid we have to bring this media conference to a close because the opening ceremony is about to go. We have to rush across the corridor and around the convention center to get to the opening ceremony, or otherwise just turn on our Zoom. But anyway, but we do have to bring this to a close. There is an opportunity for you to arrange one-on-one interviews with any of the speakers here. If there's any of the journalists wish to do that, you can do that by contacting Michael Kessler. And I want to thank all of the speakers for joining us in this media conference. Very much appreciate all of your contributions to the Union Conference, and also I want to thank the media representatives for attending this conference, this media conference, and for your support. So thank you very much, and I hope you have a very enjoyable and interesting week here at the Union Conference. Thank you.